Thank you.
Madam Chair, members, yeah, these positions are traditionally difficult to fill for the reasons that are described adequately and accurately in the agenda analysis. We are proposing to phase these 14 positions in over the entire budget year in 16-17 to give us a little bit more time. We actually I've already started to recruit and do the recruitment process in anticipation that the proposal will make it in the Budget Act. And if it doesn't, I don't want to be too presumptuous. If it doesn't, we can always pull back. But we at least have 4 months where we can kind of work on some duty statements, work on some job announcements, et cetera, to help kind of get us, again, a little bit more of a leg up. The public health micros do require a license to do their work on the bench. The research scientists, which is a can do bench work that is non-licensed, and so we try to work within that milieu to try to ensure that we hit our mark, but gives us a little more flexibility. If you note in the BCP, half of the positions are the public health micros, half are research scientists, so we have less of a challenge with our research scientists, a little bit more with our public health micros. We are doing some machinations within our hiring process, within our human resources branch, to streamline the process and make it a little bit more efficient about how we can get people to be list eligible, which we think is going to be positive. And then we're also doing some very targeted outreach, some national targeted outreach with our American Society for Microbiology, the Association of Public Health Laboratories, and other targeted outreach nationally to try to get as much interest as possible into these job classifications. So we feel with all these steps, while it's still a challenge, it's one that we think we can meet and feel confident that we'll be able to hire the 14 staff.
What's the licensure requirement? What is that? What is it?
So
for the one job classification?
Public health
there are requirements in federal law in CLIA and that to be able to conduct testing that actually is going to impact patient care, that folks have to go through a certification process that requires that they have certain years of training and actually have to take a test.
And so, like how many years? What is it? What does it look like?
You know, I don't know. I don't know if Paul is here and he knows, but it's actually very elaborate. One of the challenges is precisely that, you know, that not just anybody that has a microbiology certificate can do the job. And actually, with support from you all in the past, we actually had a small project that was geared towards helping us recruit and retain more of those microbiologists by providing educational grants and training opportunities for them. But I think that's one of the challenges that, you know, it's a very heavy kind of training, and then when we go through that frequently, these folks get taken by the private sector because we've invested in them. So it's a constant challenge. But just to go back to one thing Drew said is that because we know that only tests that are impacting patient care require this label, this type of position, we've been doing more and more in really being wise in using those people for only those tasks and actually recruiting for other classifications that are easier to hire to do some of the tests that is more for public health surveillance purposes but not impacting patient care.
Got it.
And if you look at our vacancy rates for the last many years, we actually have improved significantly. It used to be that we had vacancy rates for public health microbiologists in the 30%. Now we're into single digits, so there's still some turnover, but it's much better.
I was just trying to get a frame of reference of what that barrier could look like, right, if it was the equivalent of, you know, an extra 4 years of study, just what. So I was just curious. You finished with your presentation?
I am. Thank you.
Thank you. Any questions? Senator Stone.
Thank you, Madam Chairwoman. Could we just get back to the Zika virus again? And obviously, it's on the minds of many people in California and throughout the country, especially when we've seen some of these examples. Would you coordinate with the vector controls within the state as you see the incidence of this potentially increasing? And is the transmission of this only mosquito to human, but once a human becomes infected, can a human give it to another human?
Right. So those are excellent questions. Vector-borne, it's a very specific field, and as you know, there's local vector control districts throughout the state that in some instances are part of the local health department, in some instances they're not. So one of the things we do very frequently is, and we've been doing more along the lines with Zika, is to ensure that there is a close coordination between local vector control and local public health. when it comes to this particular problem, we actually have at 12 o'clock a meeting with the California Conference of Local Health Officers to discuss just this. One of the issues there is obviously having the vector in California and having somebody that may have traveled to a place where Zika is common and coming back infected. We want to ensure that we don't have local transmission by having people where there's mosquitoes. So it's very important that when we have a case locally, that the local health department coordinates with local vector control in those instances where there are mosquito and patients at the same time, so that they can do quick intervention in minimizing the risk of spread by a mosquito. So that is one of our goals and something that is already happening as we have patients returning to those counties where the mosquito is present. In terms of the transmission, you are correct. This is a virus that is transmitted solely by the bite of a mosquito. So it requires a mosquito vector that is this mosquito that is now present in California. And besides that, as you know, we have had instances of sexual transmission as well, so that's the other thing that we're watching closely. But it is one that is transmitted solely by the bite of the mosquito or sexually at this point.
Okay, thank you.
Elio, Finance, any public comment? Thank you very much for your
Thank you for the
testimony.
opportunity.
It's good to see you. Issue number 6, oversight of licensing and certification. Will we have the same panel that will address licensing, certification, quality improvements, and timely investigations?
That's 3 of
Okay.
us, yes.
So why don't we, I'll take public comment at the end of issue number 9, because it will hit all of the licensing and certification issue areas. Is that okay with everybody? Excellent, welcome. Let's get started on issue number 6, oversight.
Thank you, Madam Chair, members and staff. I am Jean Icino. I am the Deputy Director of the Center for Healthcare Quality. I have with me today Scott Vivona, he's the Assistant Deputy Director, and CJ Howard, who is our Chief of Policy and Planning for the Center, which includes the Licensing and Certification Program. We appreciate the very thorough write-up in the analysis, so we will just jump right into your questions. So I'm going to have CJ provide a brief summary of our licensing and certification estimate.
Thank you.
Thank you. Good morning. For fiscal year 15-16,
Did you hit your mic on for me? Oh, they just turned it on for you. Okay, thank you.
Good morning. For fiscal year 15-16, the center projects revised fiscal year expenditure authority of $251 million. This is an increase of $4.2 million or 1.7% compared with the 2015 Budget Act. This increase is the result of salary, wages, and other standard adjustments. For 16-17, the center estimates expenditures will total $264.1 million, which is an increase of $17.3 million or 7% compared with the 2015 Budget Act. This increase is the result of $6.1 million for standard adjustments, $10.6 million for the full year cost of the positions granted in the 2015 Budget Act, and $580,000 for the net cost of the HQ02, which is our budget change proposal for the timely investigation of caregivers. The timely investigation of caregivers proposal converts 18 limited term positions to permanent status and adds 2 permanent attorney positions. I'd like to note that the center's workload analysis did indicate an increase of 7.8 health facility evaluator nurse positions would be required to conduct the mandated workload. The center does not request these positions at this time. The estimated 7.8 health facility evaluator nurses, or HEFNs, reflects a change of 1.3% compared with the current staffing levels. The center expects this type of variation from year to year, as our estimate is an estimate of all the workload that we have to do.
Any questions?
Go ahead with the next.
The next was to provide an update on LNC's efforts to hire and retain nurse surveyor staff. So in 15-16, we were granted 240 positions. The department was granted 240 total positions, 146 of which were HEFNs, the surveyor staff. So to fill these positions, CHCQ initiated a coordinated statewide mass hiring effort, as we refer to it. CHCQ facilitated and coordinated the interview of Heifer candidates across all district offices. We standardized the interview process. We worked with the CDPH Human Resources Branch to streamline the review of Heifer applicants for their minimum qualifications and make sure that they had list eligibility so that we could just expedite that process of reviewing all of the applicants that we got. We sent contact or solicitation letters to all Heifers that were on the civil service hiring list in July. So that was 600 letters got sent out in July to everybody that had expressed an interest to be a Heifer. In late July, early August, we sent out a postcard to every registered nurse in California. And again, we sent out contact letters in November, and the list had grown from roughly 600 to more than 1,200 certified, or people that were on the eligibility list.
We've come a long way in a year.
Yeah, and so we're also working on a contract to evaluate and streamline our recruitment and onboarding retention efforts. And since July, CHCQ, the Center for Healthcare Quality, has hired more than 110 Heifers. So we consider that to be quite a success.
Any questions or comments? LAO, Finance, okay.
So I will provide you with an update on our oversight of the Los Angeles County contract. So the department renewed its contract with Los Angeles County for a 3-year period beginning July 1st of 2015. And the new contract includes tighter controls and very detailed specific workload performance metrics for each year. And we created a tracking sheet whereby Los Angeles County reports to us monthly on their performance in each aspect of the workload that is part of the contract. We continue to have a branch chief here in Sacramento who is responsible for oversight of Los Angeles County, and that woman travels to Los Angeles County a couple of times a month. In the Los Angeles County area, we have hired 3 staff and a retired annuitant who sit permanently in the LA County area that provide oversight monitoring on site, which includes conducting what we call state observation survey analysis, which is where our staff follow along behind the Los Angeles County surveyors to observe their work and then provide feedback after that. And we use those observational surveys to identify any additional needs for training and follow-up with the Los Angeles County survey staff. We continue to conduct quarterly audits of samples of the work done by Los Angeles County to assess the quality of their prioritization of complaints, to assess their documentation and the overall performance. And we continue to have weekly meetings with Los Angeles County and the state here in Sacramento, quarterly or so meetings at the highest levels of our department and the Los Angeles County Health Department to discuss progress on the contract. And we are pleased to say that as of August of 2015, we successfully addressed the benchmarks that had been set by the Centers for Medicare and Medicaid Services, CMS, our federal funder, to improve our management of the LA County contract.
Great. You could just roll through all the questions. And we'll
Okay.
take all the questions at the end.
Update on the status regarding meeting the new complaint timeframe requirements. So the legislation provided a year-by-year rollout of timelines for long-term care complaints. The first timeline is effective July 1st of 2016, and as of that date, we will be required to investigate complaints that involve the threat of imminent danger or death or serious bodily harm, which we call immediate jeopardy complaints, within 90 days of receipt. And we have undertaken, in addition to all of the new staffing, which will help us improve our timeliness, but takes a long time to get everybody on board trained. So we conducted a quality improvement project to help us determine how we could do this workload better, not just with more people, but do it more efficiently and effectively. We worked with contractors from Fresno State, University, who are experts in quality improvement, to implement what we call a Plan, Do, Check, Act quality improvement project. That's the model that the department is using department-wide for quality improvement, and looked at our complaint investigation process. So we formed a team with our expert facilitators that consisted of staff from the executive level to the surveyor level down to the support staff and administrative level, and included staff from across our 14 district offices, not one from every office, but from across the state. And this process begins with documenting how you investigate a complaint now, and then you identify the barriers, the roadblocks, the places where delays occur, and then you work on a process to re-engineer the investigation process. As a result of this quality improvement project for complaints, we determined, we pilot tested a complaint team model whereby one team of investigators will investigate a complaint from start to finish, uninterrupted by shifting to other workload. And that ultimately will include, they will remain on that complaint investigation process through the issuance of a citation should a citation arise. We pilot tested that complaint team model in 2 of our district offices, and 98% of the complaints that we investigated with that model during the pilot phase met the 90-day timeline. So we are now in the process of tweaking the process just to learn, to improve any things that we learned in the pilot, and we will be then rolling out the use of complaint teams to all of our 14 district offices around the state.
And we did the Heffens update earlier, question number 5.
Yes. No, actually.
Separate, okay.
Yes. The question number 5 is regarding the legislatively requested report about using staff perhaps other than registered nurses.
In lieu
to
of,
do
that's
this work.
right.
Right.
Okay.
Okay. So we did a broad look at what CMS requires to perform the workload, what other classifications are allowable, what civil service classifications, and the department has determined that we need registered nurses to do this work because of the clinical nature of the work. And even if you go out on something that seems like it doesn't have a clinical component, it may lead you to a clinical component. And in fact, we are in the middle of a reclassification process, which has been ongoing for a number of years, to rework our health facility evaluator series so that you will not be able to have a job in that classification without the possession of a registered nurse license. But we then did turn our attention to what else could we do with other classifications and save our registered nurses for the clinical work. So currently, investigating breaches of medical information in facilities is part of our registered nurse workload. So we have initiated a pilot project beginning in December 2015 using our existing position authority to hire analyst-level staff or special investigators to train them to take that breach investigation workload off of our nurses' plate. We will deploy that staff, the breach investigators, the analyst level staff, statewide, although there won't necessarily be analysts sitting in every 14 district offices, but they will take over gradually the workload of the breach investigations. And we will report to the legislature annually in our estimate of how that workload is going. And then if we find that to be a successful project, we will look to expand the use of the analyst classifications to do that portion of the workload and free up the registered nurse staff.
Excellent. Wait, let me turn the page, make sure I'm not missing anything. No, with that, I'm going to open it up to questions.
Can we go back to the LA County contract? You kind of glossed over the fact that there's been some issues with them. There was a 2016 survey, SOSA survey, that showed that there were problems involving sample selection, general investigation, and deficiency determinations, and then they subsequently had a joint meeting with Centers for Medicare or Medicaid Services on April 16, and then you're saying they met federal standards, I think you said in August of 16. It seems like when they've had issues, we just kind of request corrective action. And is that the same playing field with other counties, if you will, when we oversee them, as opposed to abrogating the responsibility to the county to do it themselves? Do we fine people or organizations that don't follow the protocols and just give them slaps on the wrist? And then also you said you hired some additional people to oversee the LA County contract. Is that factored into the overall budget of that contract? Because we know it's more expensive than our ability to provide the same services.
Okay. I'll try to take the pieces, and then you can remind me if I missed some aspects of your question. So when we identify concerns with any aspect of the work that's being performed by Los Angeles County, we use that as an opportunity to identify if additional training is needed, but we also do issue in writing a summary of our concerns and request, as you mentioned, a corrective action plan from Los Angeles County about how they're going to address that concern, and part of that might be additional training from us. So that's how we hold them accountable for the concerns that we find.
What if they don't comply?
I'm sorry?
What if they don't comply? What are the sanctions that the state can impose upon them, if any?
We don't have specific sanctions in the, as I understand your question, it's if we find that in a particular survey we observe something that wasn't up to par, we don't have a means to sanction them financially. We work with them to develop a plan so that that doesn't happen again. You could potentially have the same situation in any district office where our state surveyors are doing work, and in fact we are rolling out these kinds of sample audits of look-backs of surveys with our own staff, as this is part of a quality improvement loop. And we are doing that now with our own staff. That was a recommendation from one of our BSA audits that we roll this out to the rest of our staff. And so it's part of a continuous quality improvement loop to identify where you have things that need to be addressed and then work on a plan to improve that.
But is it fair to say in other areas of the state where you have direct jurisdiction that if you saw the same issues that you would not have any sanctions other than a corrective letter saying you need to correct these issues?
Yes, when we were working with our own staff, it wouldn't be even as formal as rolling out a letter. We would work with the management in that district office to work on whatever was needed, either improving procedures in the district office or working with the individuals if there was an individual level issue.
Are there any incidents outside of Los Angeles where you ask for corrective action and the corrective action is not done?
No, we don't go to the formal step of requesting a corrective action plan in our state staffed offices.
So who ensures that corrective action is actually followed through with in the best interest of?
That's the responsibility of our management. We have branch chiefs that have regions of district offices, and they travel to their district offices and meet with them, and each district office has a district office manager, and so it's a staff management responsibility. They report, so branch chiefs have oversight of all of our district offices, just as we have one branch chief who oversees Los Angeles County.
Okay. Okay, thank you.
You? Leo? Excellent. With that, reminding everyone, we're going to hold public comment until we get through all of the issues under this department. So let's move on to, thank you for the report, the oversight. Let's move on to program quality improvement projects, page 28 of the agenda.
Yes, so this is our one of our budget change proposals for use of our IDQIA funding, and CJ is going to adjust that.
In 1617, CHCQ proposes the licensing and certification program quality improvement projects budget change proposal. This is to support two projects totaling $2 million from the internal departmental quality improvement account, or IDQIA. One project is for $500,000 to support the redesign of the Health Facilities Consumer Information System, or HIFCIS, which is a public-facing website that enables consumers to access information regarding healthcare facilities and the quality of care provided therein. The second project is to redesign the Centralized Applications Unit IT systems. The Centralized Applications Unit IT systems will be redesigned to replace paper-based processes with information technology solutions that will enable public health to comply with Affordable Care Act requirements for tracking facility ownership and streamline the processing of licensure applications and change of ownership applications. There was another question regarding the current year contracts.
Yes, so two of the recent projects that were completed using the money from this fund were a re-engineering, business process re-engineering overviews of our professional certification branch and our centralized applications unit. And they have brought to light issues for us that we're well underway trying to improve. In particular, in our centralized applications unit, we are moving to truly fully centralize the entire application licensing process and change of ownership process for the entire state. We had a piece of it in Sacramento, and then parts of it were happening in our district offices, and we are now moving that all up to headquarters. We have hired additional staff, and that unit has grown from 8 to 21, and then we're looking to automate processes in that unit, and that's part of the money that we also, for that automation project, will use from this fund. So that was one outcome. The re-engineering, redesign in our professional certification branch helped us identify ways to improve our tracking of complaints. They helped us significantly in updating our policies and procedures, which is an issue that the auditor had raised with us. And they encouraged us, which we have gone forward to do, to license with a commercial database to help us with background investigations when we're investigating complaints about individuals. We've also used some of that funding in the past to hire a project manager who is helping us continue to implement our Hubbard report recommendations and to bring those projects to closure, and is providing change management training not only for the management in Sacramento, but then rolling out to all of our staff, as was a Hubbard report recommendation.
With that, seeing no questions from my colleagues, let's move on to issue number 8, timely investigations of caregivers.
And this is our other budget change proposal.